So the considerations when discussing treatment options for this patient really are the classic therapeutic index. What are the potential benefits, especially if you're going to add a targeted agent, versus what are the potential risks? Setting an expectation on average that in this third line metastatic setting, the drugs will work somewhere between 10 to 12 months is kind of what I would discuss with the patient. If the patient asks, how long do you think this would work? I'm going to give her an estimate of somewhere between 10 to 12 months. And I'm extrapolating many studies in patients who have hormone-sensitive breast cancer. And really, the data for the use of chemotherapy is about the same. The best that you would see with oral chemotherapy, in particular capecitabine, is about 9 to 10 months. So I would explain to her that both options, on average, is somewhere between 10 to 12 months benefit if she responds initially. So I don't see a huge discussion point with patients about one clearly is going to work better than the other. So it really then boils down to what are the kind of life impact factors or the potential risk. And obviously with oral chemotherapy, there's side effects such as oral capecitabine, there's side effects such as the rash and diarrhea, which can be quite problematic. We just don't quite got the dosing right, and it's very patient dependent. If I was going to choose exemestane and everolimus, we'd have to have a fairly frank discussion of that, although this is a highly targeted agent that targets the PI3 kinase pathway, it can have side effects very similar to chemotherapy. You can get mucositis, so you need to let us know and take it very seriously. There's an increased incidence of anemia and fatigue, very similar to what we see with chemotherapy. So I wouldn't set an expectation that adding whether it be everolimus or CDK inhibitor is going to be just like having anti-estrogen therapy alone. It's not. There's added side effects. But I think it's worth doing at this point because I think those side effects are less than with the oral chemotherapy. So I'd set an expectation of somewhere between 10 months to a year on average for the use of either capecitabine or anti-estrogen therapy with a targeted agent. And I would talk to her about why I would choose the anti-estrogen backbone of exemestane because it's dissimilar to what she's had before. If she really said anastrozole made my life miserable, then I would consider using tamoxifen in combination with everolimus. But I would take the side effects of the everolimus quite seriously. And in my practice, I would tell her that we would need to see her every 2 weeks, at least for the first month, so 2 visits, not different than what you would see with oral capecitabine, where you have to see patients every 3 weeks. So we would see her every 2 weeks, we'd monitor her blood count, see how she's doing, and then we expand it out to about once a month. And that's typically how often patients are coming in for the denosumab anyway. So it makes it actually a very user-friendly regimen, especially when it works.